I'm Ashley, and it's time for maternity nursing, so let's get started. To begin with, if someone is pregnant, normally their periods will stop. So, what is the name of the hormone that induces amenorrhea? I'll give you a hint. It's not HCG, and it starts with a P. Did progesterone just pop into your mind? Yes! Increased progesterone levels cause amenorrhea. HCG always sounds right in OB, doesn't it? Yes, because HCG is what shows up in your urine to make a pregnancy test positive. But it's wrong here. Progesterone is what induces amenorrhea. Let me stop right here and talk about conception for just a minute. Now, this is not in your student pages, so you can just listen. Progesterone is also what makes your temperature go up after you have ovulated. That is important to know if you have someone who is trying to get pregnant and they are keeping a temperature chart. When they see the spike in their temperature, they know they have already ovulated. Do you remember how long the egg is good for? 24 hours, and sperm can survive in the vagina for 3 to 5 days. So, when you're counseling a client that's trying to get pregnant on when to have sex, what would you tell them? Well, if they wait until the temperature has already gone up, they don't know how long the egg has been out there. It could almost be worn out, right? Yeah. So what you tell them is to keep a temperature chart for a couple of months, and that way they can learn how to anticipate when they think their temperature is going to go up. They should start having sex before the temperature goes up. Now, don't ask your husband how often you're supposed to have sex, because what is he going to say? Every day. No, not every day, because you don't want the sperm count to drop. You want to have sex every other day if you're trying to get pregnant. All right, let's move on and look at the signs and symptoms of pregnancy. Signs and symptoms of pregnancy can be classified as either presumptive, probable, or positive. So let's start with presumptive. What does presumptive signs mean? Well, these signs suggest or indicate pregnancy, but they could be attributed to something else. Presumptive signs are things that the client will recognize. So, presumptive signs of pregnancy include things like amenorrhea, nausea and vomiting, urinary frequency. Again, urinary frequency. Y'all, frequency can be the very first sign of pregnancy because almost immediately after implantation, what does the uterus start to do? Stretch. And that stretch puts pressure on the bladder. Also, breast tenderness is a presumptive sign, and it can occur throughout pregnancy because of the excess hormones in the body. Okay, let's look at probable signs of pregnancy. Probable signs are things that most likely indicate pregnancy and are signs the primary healthcare provider will identify. So first, we have a positive pregnancy test. A positive pregnancy test is only a probable sign because it is based on the presence of HCG levels. There are other conditions that can elevate HCG levels, like a hydatidiform mole or a molar pregnancy, or even some drugs. A hydatidiform mole is a benign neoplasm of grape-like vesicles that can become malignant. If not malignant, a D&C is required with close follow-up for 6 months to 1 year. Now, if the molar pregnancy is malignant, treatment will be based on the stage and grade of the cancer. Goodell's sign is another probable sign of pregnancy, and it is softening of the cervix. Again, softening of the cervix. And this occurs around the 2nd month. Chadwick's sign is a bluish color of the vaginal mucosa and cervix. It is due to vasocongestion, and it occurs about the 4th week of pregnancy. Again, the 4th week of pregnancy. And Hagar's sign is softening of the lower uterine segment, which occurs about the 2nd or 3rd month. How many times have you heard your friend say, "Oh shoot, I just had Hagar's sign"? Never, right? You won't hear your friend say that. You hear your friend say things like, "I missed a period," or "I have breast tenderness." These probable signs we are going over are the things the primary healthcare provider is going to find, right? Yes. Okay, next is uterine enlargement. Well, you might notice something if your uterus starts to enlarge, right? And we have Braxton Hicks contractions, which occur throughout pregnancy. Again, throughout pregnancy. They help move blood through the placenta and will increase in frequency as the pregnancy progresses. You may also see pigmentation changes of the skin like linea nigra, which is the dark line down the center of the abdomen, and facial chlasma, also known as the mask of pregnancy. And we all know about the dreaded abdominal striae, better known as stretch marks. And lastly, they can have darkening of the skin around the areola. Now, positive signs of pregnancy are easy. If you have these signs, you are definitely pregnant. Because if you hear the baby's heart beating, it's a pretty positive sign that you're pregnant. You can hear the heartbeat by Doppler at 10 to 12 weeks. 10 to 12 weeks. And with a fetoscope at 17 to 20 weeks. Again, 17 to 20 weeks. Fetal movement is considered to be a positive sign. Now, when I say fetal movement, I do not mean the client telling you they feel the baby move. I mean you, as the nurse, feeling the baby move. Ultrasound. Well, that's an easy one. If they do an ultrasound and see a baby in there, you're pregnant, right? Positively. Okay, let's move on and look at some pregnancy terms. Gravidity is the number, again, the number of times someone has been pregnant. Now, does the duration of the pregnancy have anything to do with it? No, duration has nothing to do with gravidity. For instance, you can have somebody that's a gravid of 5 and they have no children because they've miscarried every time, but that's still somebody that's been pregnant 5 times, right? Now, parity is next. This is the number of pregnancies in which the fetus reaches 20 weeks. The number of pregnancies that reaches 20 weeks. Next is viability. 24 weeks, again, 24 weeks gestation and beyond is considered to be the age of viability. This means the infant has the ability to live outside the uterus. Now, I don't want you to confuse parity with viability. A 20-week baby is not considered viable. Again, is not considered viable. When a baby is born at 20 weeks, it will not be a live birth. All right, TPAL is the acronym that gives you further information on parity. T equals term, P equals preterm, A equals abortion, and this includes spontaneous and elective abortions. And L is living children. A spontaneous abortion is also called a miscarriage. If your client is bleeding, cramping, or has a backache, think miscarriage. The HCG level will begin to drop with an imminent miscarriage, and most miscarriages occur before 20 weeks. Now, Nagel's rule is the formula used to determine the due date, or EDD, which is just the estimated date of delivery. To start, you find the first day of the last menstrual period and add 7 days. Then you subtract 3 months and add 1 year, like 2018, 2019. Add 7 days, subtract 3 months, and add 1 year. Depending on the time of the year the client becomes pregnant, you may not need to add a year. And remember, Nagel's rule is only accurate plus or minus 2 weeks. Again, plus or minus 2 weeks, because ovulation and conception can occur 2 weeks before a period or mid-cycle. Okay, let's look at trimesters of pregnancy. We're going to start with the first trimester. This is week 1 through week 13. I'm not going any further back than that. Anything before the first trimester, you're on your own, okay? In the first trimester, you always want to think about client education and teaching. And the first thing we're going to start with is nutrition. During pregnancy, it is important for the expectant mom to follow a well-balanced diet. They should increase their protein intake to 60 grams per day. Again, 60 grams per day. Here's the deal. The normal protein intake is about 40 to 45 grams per day. But when you're pregnant, you have a lot of tissue growth going on in your body, so you need more protein. Also, don't forget about culture when teaching a patient about nutrition during pregnancy. There are many cultural beliefs that relate to nutrition, such as hot versus cold foods, kosher foods, and fasting. Next is weight gain. How many pounds or kilograms do we expect them to gain in the first trimester? It's not many, 1 to 4 pounds or 1.8 kilograms. Again, 1 to 4 pounds or 1.8 kilograms. That's the average. Now, remember, again, this is the average. It will also be dependent on what their starting BMI is. You know that some people gain a lot more than that, right? Yes, and some people lose weight because they are very sick. Now, prenatal vitamin supplements. These days, they tell you that if you even think you might get pregnant, you need to go ahead and start taking a prenatal vitamin, right? Now, a lot of people don't like to take vitamins because of the iron. So you must teach them the importance of vitamins so they just don't stop taking them. What are the biggest complaints with iron? Constipation and GI upset. Again, constipation and GI upset. We always tell people to take iron with food, right? Yes, to decrease GI upset. But is that the very best way to take iron? No. The best way to take iron is on an empty stomach. But how many people can handle that? Not many because of the associated GI upset. That's why we say always take iron with vitamin C. Again, with vitamin C. Well, why? Because vitamin C enhances iron absorption. Now, if they simply cannot tolerate iron, can we teach them foods that are high in iron? Yes, in fact, these would be good to teach even if they are tolerating their iron supplement. Now, we all know that liver and spinach are good sources of iron, but lentils, raisins, fortified cereals, dark chocolate, and dried fruits are also good options. Okay, next is folic acid. Folic acid helps to prevent what kind of defect? Neural tube defects. Neural tube defects. Spina bifida or myelomeningocele and anencephaly are the big neural tube defects we think of. And they need to take at least 400 micrograms, again, 400 micrograms per day of folic acid. Next is exercise. No high impact. Walking and swimming are the best. Again, walking and swimming. They should not start a heavy exercise program, but they can continue with their regular exercise program. Now, I do not care how well conditioned an athlete you are. If you become pregnant, everybody should follow this rule. Don't let your heart rate get above 140. Because if your heart rate gets above 140, what two things are going to drop? Your cardiac output, again, cardiac output and uterine perfusion. When you have a decreased cardiac output in a pregnant person, who's not getting blood? The baby. That's not good. And that's why you never want decreased cardiac output in a pregnant person. We also do not want them to get overheated. So do not let mom get into hot tubs or under heating blankets because this will increase body temperature. Again, this will increase body temperature and cause birth defects. Next is danger signs. Now, most of these danger signs are seen in the third trimester, if they happen at all. But I am talking about them now in the first trimester because when I get that client in, I'm going to tell her everything I can because is there a chance that I will never see her again? Yes, so teach them everything you can. Another thing is this. When people are coming into the primary healthcare provider for their first prenatal visit, they are usually excited. Remember the adult learning theory? Adults must be ready and motivated to learn? Yes. And at the first prenatal visit, they want to know everything, right? They are ready to learn. Okay, back to danger signs. Sudden gush of vaginal fluid, bleeding, persistent vomiting, again, persistent vomiting, severe headache, abdominal pain, increased temp, edema, no fetal movement. Again, no fetal movement. And guys, this is big because decreased or no fetal movement is the most common sign and symptom associated with an adverse labor and delivery outcome. All right, let's switch things up a little and do a critical thinking exercise. What if I have been pregnant 4 times and now I am pregnant with my 5th baby and I call you one day at the OBGYN clinic and I say to you, you know, this baby's not moving as much as my other babies. Do you say, all pregnancies are different, or call 911? If you want to make the NCLEX lady happy, you call 911, right? Now, you know that they usually go to the primary healthcare provider's office for an evaluation, and the primary healthcare provider may decide it's nothing to worry about. But to the NCLEX lady, saying all pregnancies are different is brushing off the client's complaint. You never pick an answer where you are brushing off the client's complaint because we are always going to assume the worst. I know you're not going to say call 911. I was just illustrating a point to you. You assume the worst about this situation because what did I just say? Decreased or no fetal movement is the most common complaint associated with poor outcomes. Now, there's a chart in your book that has the danger signs and complications of maternity that you need to review later. Okay, the next thing is common discomforts. Look at the common discomforts in your student pages and see if you start getting in the mood to get pregnant. Are you getting in the mood? All right, think about your best friend being pregnant. Now, I know he's a man, but he's pregnant too in our little game. And he's constipated. So tell me how to alleviate their constipation. And you better not tell me to give them milk or magnesia. You say eat more fiber, drink a lot of water, and walk a lot. You know what to do. Now your pregnant friend has ankle edema. What are you going to tell them? Elevate. Maybe they have nasal congestion. What are you going to tell them? You cannot do what your OBGYN let you do. Because a lot of primary healthcare providers let you take things like Sudafed, Actifed, or Benadryl. Are you going to pick those on NCLEX? No, because if you pick that, you are telling the NCLEX lady that you are going to let pregnant ladies take drugs. Is that a nice message to send? No. The only thing you can do is let them try something like a nasal saline spray or steam. Y'all, anybody that is pregnant has a lot of extra estrogen in their body. And estrogen causes nasal congestion. That's why females, before they start their periods, often get a headache. It's the excess estrogen. Now, medication is next. What are you going to tell the pregnant client about taking any medicine? No medication unless you ask the primary healthcare provider. Again, no medication unless you ask the primary healthcare provider. You know that. You've got to forget what your primary healthcare provider let you do. What are you going to tell them about smoking? Stop. We know they need to stop smoking. And if they still have to smoke, would you rather them smoke inside or outside the house? Go outside so they won't re-inhale so much secondhand smoke. Now, what is smoking during pregnancy associated with? Small for gestational age, low birth weight babies, again, low birth weight babies, cleft lip or palate, and the risk for placental abruption doubles with smoking. So they need to stop smoking. Okay, let's look at primary healthcare provider visits. How often should a pregnant client visit the primary healthcare provider during the first 28 weeks? Once a month. Again, once a month. What about 28 to 36 weeks? Every 2 weeks or twice a month? Again, every 2 weeks or twice a month. Well, what about after that? Weekly until birth. And if the client is high risk, she will have more prenatal visits. Next is ultrasound. Before an ultrasound, what will you ask the client to do? Drink, void, drink, void. Well, which one is it? Well, we drink water to distend the bladder. So why would you ask them to drink before an ultrasound? They drink water to distend the bladder, because when you distend the bladder, that pushes the uterus where? Up closer to the abdominal surface. Now, if the uterus is closer to the surface, it is easier to get a good picture. Now, if your client is having a transvaginal ultrasound, the bladder does not have to be full. What about an ultrasound before a procedure, like an amniocentesis? Now we want them to void, okay, again, to void. If it's an ultrasound before a procedure, like an amniocentesis, then they should void to decrease the risk of accidental puncture of the bladder. All right, moving on to the second trimester. This is week 14 through week 26. Now they can begin to increase their calories. What is the recommended calorie increase for the second trimester? It's not many. 300 calories a day. Again, 300 calories a day. Now that is only about 1 1/4 Snickers bars. It's not much. And if they're an adolescent, they can increase their calories by 500 per day. Again, 500 per day, because you are accounting for their own growth and the baby's. The next things in your student pages is weight gain. Tell me the expected weight gain per week. In general, it's 1 pound. Again, 1 pound. But this is variable depending on the woman's BMI pre-pregnancy. Should the client still be experiencing nausea and vomiting? No nausea and vomiting. What about breast tenderness? Yes, they may still have some breast tenderness. Now, here is the tricky one. Urinary frequency. What do you think? No, you have got to forget about when you were pregnant, because most pregnant women will tell you they had frequency the whole time. So let's talk about why the answer is no. In the first trimester, the uterus is a pelvic organ, isn't it? Yes. Now, in the second trimester, what does the uterus do? It rises and relieves pressure on the bladder. So no to frequency in the second trimester. What is quickening? Fetal movement. Again, it's fetal movement. Now, usually they can feel quickening around 16 to 20 weeks. Now, the more babies you've had, the sooner you feel it, right? Yes. Okay, what should the fetal heart rate be during the second trimester? 110 to 160. 110 to 160. And if it's less than 110, panic. Now, even though the book says 110 to 160 is okay, we are watching the heart rate closely and being cautious. All right, the next thing we have is Kegel exercises. Now, it is never too early to start these. Okay, everybody together, let's go. Kegel. And you knew exactly what to do, didn't you? Yeah, all you do is tighten your pubococcygeal muscles that work to stop the urine flow. So during these exercises frequently help to strengthen the pubococcygeal muscles. Now, men and women can do these, can't they? Yes, they can. Men do these after what surgery? Any kind of prostate procedure. Now, these muscles, the pubococcygeal muscles, help stop the urine flow when you want to stop it, right? Yes, and they also keep your uterus from falling out, which sounds like a big problem to me. Okay, third trimester, week 27 through week 40. First, let's get term pregnancy straight. A pregnancy is considered term if it advances to 37 to 40 weeks. Again, 37 to 40 weeks. Now, assessment in the third trimester. Tell me the weight gain per week now. Did you say no more than 1 pound a week? Yes, no more than 1 pound a week. Again, I'm being extra cautious. Anytime you see a mom that has gained more than 1 pound in a week in the last trimester, we have to assume the worst. Monitor blood pressure and report any increases. Again, any increases from the baseline, because they might be developing what? Preeclampsia. Preeclampsia develops after 20 weeks gestation, and the client will have increased blood pressure, proteinuria, again, proteinuria, and edema. Now, the two I'm scared of are increased blood pressure and proteinuria. These are the ones that indicate trouble. Lots of pregnant women have swelling and edema with no other problems. So let's say I'm in my third trimester and I come to the primary healthcare provider and they weigh me and I've gained 5 pounds. Well, they're going to check some things. They're going to check my blood pressure and they're going to check my urine for protein. Now, underline this next sentence. 2 or more pounds of weight gain in a week. Watch closely and worry about possible preeclampsia. What are we worried about with preeclampsia? A seizure. We worry that the client with preeclampsia can have a seizure. Now, for severe preeclampsia, what is the drug of choice? Well, first of all, severe preeclampsia is defined as a blood pressure of 160/110 or greater that is documented 6 hours apart. So, what is the drug of choice? Magnesium sulfate. Magnesium sulfate is the drug of choice for preeclampsia. It is given IV in a hospital setting under close supervision. Now, magnesium sulfate does 3 things. It acts like an anticonvulsant, it sedates, again, sedates, and it vasodilates. Now, if it vasodilates, magnesium sulfate will help to lower the blood pressure, increase renal perfusion, and increase placental perfusion. Now, these are all good things for the mom with preeclampsia, right? Yeah, it is. Okay, what is the difference between preeclampsia and eclampsia? The seizure. It is called eclampsia when they have a seizure. Okay, back to the third trimester. What should the fetal heart rate be? It is still 110/160, 110/160. Now, how is fetal position and presentation determined? What's the name of those maneuvers? Leopold maneuvers. Again, Leopold maneuvers. Now, what we're doing with Leopold maneuvers is you're palpating around the abdomen trying to find the baby's head, back, and booty. Why do I care where the baby's back is? That's where you listen for what? The fetal heart rate. It's over the fetal back. That's where you put your Doppler. Now, what should you have your client do before you do Leopold maneuvers? Void. Have them void. That's a comfort measure for one thing, but also, I bet your teachers told you that when you have a distended bladder, it can push your uterus one way or the other, right? So you have them void first. Now, if the client is having contractions, should Leopolds be done during or between contractions? Between, that's right, between contractions. If you try to do the maneuvers during a contraction, what are you going to feel? A hard uterus. You are not going to feel the baby. Now look at client teaching with me under signs of labor. The first thing in your student pages is lightening. It usually occurs 2 weeks before term. Again, 2 weeks before term. And this is when the presenting part of the fetus, which is usually the head, descends into the pelvis. The client will notice that she is able to breathe more easily, and this is because the pressure on the diaphragm has decreased. But this puts more pressure on the bladder, so urinary frequency, again, urinary frequency becomes a problem again. Now, I don't want you to get lightening and engagement confused. So let's look at engagement. Engagement is when the largest presenting part of the fetus, and again, we hope it's the head, is in the pelvic inlet. So if the presenting part is at the 0 station, the baby is getting down in the birth canal, right? All right, let's do an NCLEX critical thinking exercise. When the membranes rupture, I hope the baby's head is well engaged, because when membranes rupture, there is a sudden gush of fluid. If the baby's head is not well engaged, what might come out with the fluid? The cord. Now I've got a prolapsed cord. But if the head is engaged, that cannot happen, right? When the client reports ruptured membranes, the first thing I want you to think of is a prolapsed cord unless proven otherwise, and they need to come directly to the hospital. And always obtain fetal heart tones after the membrane's rupture because we need to know that the baby is stable. Now look at fetal station. Fetal station is measured in centimeters, and it measures the relationship of the presenting part of the fetus to the ischial spines of the mother. Now, don't stress about the fetal stations. They will not ask you things like this on NCLEX. We're just trying to explain these words to you in case it's given to you in a question, so you will understand the concept. Okay, other signs are Braxton Hicks contractions. They will be more frequent and stronger than before. Softening of the what? The cervix. Softening of the cervix. Now, I'll bet your teacher told you that in the non-pregnant female, the cervix feels like the tip of your nose or your chin or even a pencil eraser. But when you're pregnant, the closer you get to time of delivery, the softer it gets. It gets really, really soft. Have you ever heard OB nurses say that the cervix is ripening? That is what we're talking about here. The softening that has to occur before the cervix will dilate. Bloody show is another sign. Now, with the bloody show, do you expect to see heavy bleeding? No. If you see heavy bleeding, think hemorrhage. Or if you see a thin, continuous trickle of blood, think hemorrhage. Now, when they get that sudden burst of energy, what is that called? Nesting. It's called nesting, like making your nest. Mother Nature's way of helping you get ready for the baby. Now, a lot of ladies never experience this, but they wish they could have. So don't get your feelings hurt if this doesn't happen. And people will tell you that if you do get a sudden burst of energy, you're probably going to have the baby within the next 24 to 48 hours. Diarrhea is also something the mother might develop prior to delivery. And again, rupture of membranes. Rupture of membranes. Now, when should the client go to the hospital? When the contractions are 5 minutes, again, 5 minutes apart, or when the membranes rupture. What are you worried about when the membranes rupture? And I'm going to give you 2 options: infection or prolapsed cord. Well, both answers are good, but here's the deal. Always pick the killer answer. We're going to be checking their temperature often to watch for infection, but it takes longer for an infection to set in than it would for a prolapsed cord to kill the baby. So you have to pick prolapsed cord. Again, both answers are good, but prolapsed cord is your priority answer because that's the one that can kill the baby immediately. Now, I'm not saying infection like chorioamnionitis is not important because that can happen too. But when there's something more acute, pick that. Okay, let's move on to diagnostic test. The non-stress test is first. With a non-stress test, you want to see 2 or more accelerations of 15 beats per minute or more with or without fetal movement. You will also see that we put a definition of accelerations in your student pages that you can review later. Each increase should last for 15 seconds, again, last for 15 seconds, and is recorded for 20 minutes. Now, do you want this test to be reactive or non-reactive? Reactive. We want the test to be reactive because what does reactive mean? Reactive means that accelerations are present. All right, if I were to sit down in a chair right now, what is my heart rate going to do? It's going to slow down. And if I jump up and start lecturing again, what's my heart rate going to do then? It's going to go up. So what I'm asking you is this: do I have variability in my heart rate? Yes, I have variability. So don't we want the baby to have variability? Yes, variability is a good thing. We want them to have it. Y'all, if you've got a baby that cannot get their heart rate up or keep it elevated for 15 seconds, are they going to be able to tolerate the stress of labor and delivery? No. So we worry if the non-stress test isn't reactive, and we continue to evaluate and plan. Next is the biophysical profile test. Once the results of the non-stress test are known, a biophysical profile test or BPP may be done. It is commonly done in the last trimester, again, the last trimester, but it can be done as early as 28 weeks in a high-risk pregnancy. Some women with high-risk pregnancies may have a biophysical profile test every week or even twice a week in the third trimester. The measurements are obtained by ultrasound, and each of the parameters count 2 points. Again, 2 points, and 10 out of 10 is a perfect score. The parameters are heart rate, muscle tone, movement, again, movement, breathing, and the amount of amniotic fluid around the baby. With the BPP test, the observation time is 30 minutes. Again, 30 minutes by sonogram. The results are evaluated as 8 to 10 is good. 6 is worrisome. They should consider repeating the test in 24 hours. And less than 4 is ominous. Consider immediate delivery. The primary healthcare provider may decide to deliver if the BPP score is 6 or below. Now, let's look at the contraction stress test, and we're going to focus on the oxytocin challenge test. Oxytocin, oxytocin is administered to stimulate contractions. And don't worry, we will talk about oxytocin again in a few minutes. Now, this test is generally done when the non-stress test is non-reactive. Now, read with me in your student pages. Performed on high-risk pregnancies like preeclampsia, maternal diabetes, or any condition in which placental insufficiency is suspected. This test determines if the baby can handle the stress of a uterine contraction. Again, of a uterine contraction. Uterine contractions decrease blood flow to the uterus and to the placenta. Well, if the blood flow decreases enough to cause hypoxia in the fetus, then the fetal heart rate will decrease from the baseline. This is called a deceleration. Again, a deceleration. And what type of decelerations do we not want to see on the fetal monitor? Late decelerations. Because late decelerations mean uteroplacental insufficiency, which basically means the placenta is wearing out. Now, do you want a positive or a negative test? Negative, a negative test. What does negative mean? No late decels. A negative test means there are no late decelerations. This test is rarely performed before how many weeks? 28 weeks is what I want you to write down. 28 weeks. Now, why is 28 weeks the answer? Because are we inducing a contraction? Yes. When you induce a contraction, what might you get at the end of the contraction? A baby. So that's why we would never want to do it earlier than 28 weeks, because you could end up with a premature baby. Now, I want to make one more point about this test. The results are only good for 1 week. Again, they are only good for 1 week. So let's say that I'm a high-risk pregnancy. I'm pregnant with triplets and I go in for my oxytocin challenge test. They induce contractions and don't see any late decels. Okay, so no late decelerations. What are they going to do? Send me home, right? Yes, send me home until next week. So I come back a week later, and this time I'm having late decels. What are they going to do? Plan for delivery. Go ahead and put me in the hospital, right? Yes. Y'all, contractions occur in the portion of the uterus where the placenta is located, and contractions squeeze the placenta. So if I'm having late decels, the placenta is wearing out. I have uteroplacental insufficiency. In the book, you have a box with the types of decelerations defined for you. All right, let's recap because this is very important. In a non-stress test, we are looking for accelerations in the heartbeat. Accelerations are reactive. We want reactive. In a contraction stress test or oxytocin challenge test, we are looking for late decels. No late decels means negative. We want negative. Let's move on and look at labor and delivery. First, we have true labor. With true labor, do we have regular or irregular contractions? Regular contractions. Do contractions increase or decrease in frequency and duration? Increase. They increase. The discomfort is often in the back and it radiates around to the abdomen. What happens to the pain level with the change in activity? It increases. Again, it increases. Now, false labor. With false labor, the contractions are irregular. Again, irregular. And where is the discomfort mainly? The abdomen, just in the front. The abdomen, just in the front. What happens to the pain with a change in activity? It decreases or it goes away. Again, it decreases or goes away. Y'all, these are Braxton Hicks. If somebody is having Braxton Hicks, they can do just about anything different, like get up and walk, drink a glass of water, or roll over in bed, and they usually go away. Next is premature labor or preterm labor. This is labor contractions that occur with dilation, again, with dilation, between 20 and 37 weeks. The goal here is to stop labor. Treating any existing vaginal or urinary tract infections and hydrating, again, hydrating the mom will often stop preterm labor. The client will be placed on bed rest. Some medications that may be prescribed are magnesium sulfate IV because it relaxes the uterus, betamethasone IM, which is a steroid that helps the fetal lungs mature, terbutaline sub-Q, indomethacin PO, and nifedipine PO. Okay, next is miscellaneous information. The first thing is epidural anesthesia. I know that ladies in labor can get different types of pain meds, but we're going to focus on the epidural. So let's talk about how we would position the client for an epidural. One position is the client can lie on their left side, legs flexed. A very common position that they use is to have the client prop up over the bedside table. Now, there are other clients in the hospital that have epidurals besides pregnant women, right? Yes, lots of people get epidurals these days. But in the labor patient, an epidural is given in stage 1 at 3 to 4 centimeters. Again, 3 to 4 centimeters dilation. Usually there is not a headache because they don't get into the spinal fluid. Now, what is the major complication of an epidural? Hypotension. Again, hypotension. Their blood pressure can drop out quickly. So we're going to be monitoring their blood pressure closely. One way we combat the hypotension is by giving them IV fluids. Bolus the client ahead of time with 1,000 milliliters of normal saline or lactated ringers to fight hypotension. We are building up that volume, right? Yes, because these are what type of fluid? Isotonics, and we know that isotonics stay where you put them. We can change their position. Put the client in semi-Fowler position, tilted on their side to prevent vena cava compression, because vena cava compression will decrease venous return, which reduces cardiac output and blood pressure. If my blood pressure is decreased, what happened to perfusion of the placenta? It decreases. Placental perfusion decreases. And do I ever want a decrease in placental perfusion? No. So be sure to tilt them on their side in semi-Fowler's position. And their position will need to be alternated from side to side hourly. Again, alternated hourly. Now, because of reduced sensation, don't forget to check their urine output and assess the bladder. All right, let's look at the client receiving oxytocin. Nursing considerations are first. Y'all, oxytocin is designed as a high-risk alert drug. This means there is a high risk of client harm, so never underestimate the problems that can occur with oxytocin administration. They need one-on-one care. Now, I know that's not what you saw in the hospital, but if you're a brand new nurse and you've got somebody on oxytocin, the NCLEX lady does not want you to leave the client. You stay with them because you are a brand new nurse and a lot of complications can occur, correct? Yes. So be aware of complications such as hypertonic labor, fetal distress, again, fetal distress, and uterine rupture. The uterus may rupture due to rupture of the scar from a previous C-section. See where it says that VBAC moms are at a high risk for uterine rupture? It's because the scar can rupture. As a brand new nurse, you consider every VBAC as a high risk for uterine rupture. Also, uterine surgery or trauma, malpresentation of the baby during delivery, or a difficult forceps delivery all increase the risk of uterine rupture. Now, with oxytocin administration, we want a contraction rate of 1 every 2 to 3 minutes, with each contraction lasting 60 seconds. Do we want to pause between contractions? Yes, you've got to have a pause because it's during that pause that the baby gets oxygen. We are going to discontinue the oxytocin when the contractions are too often. Again, when they're too often. When the contractions are lasting too long, or with any sign of fetal distress. Any sign of fetal distress. Oxytocin is piggybacked into a mainline IV fluid, so when you discontinue the oxytocin, make sure you do not turn off your main IV fluid. What position should the client receiving oxytocin be placed in? Any position except flat on their back. Now, if the client has any unreassuring fetal heart tones, again, fetal bradycardia, for example, then we will put them on their side to enhance uterine perfusion. Remember, placing any pregnant client flat on their back is contraindicated. Now, what should be done with the oxytocin infusion if late decels occur? Turn it off. Don't decrease it. Turn it off. Okay, you have a medicine alert box in your student pages for oxytocin, so be sure and review it later. All right, let's move on to emergency delivery. Now, when I said emergency delivery, I did not mean an emergency delivery in the hospital, because you have supplies there, don't you? Yes, I'm talking about an emergency delivery in the woods somewhere. And y'all, talking about emergency deliveries, let me tell you an inside scoop we here at Hirsch Review know about that nobody else knows. The Duke and Duchess of Cambridge, you know, Kate Middleton and Prince William of England, their first baby was an emergency delivery. You see, Kate was pregnant right at term, and she and Prince William went to visit their country home at Amner Hall. It was just them and the butler. And when they got there, it was decorated all pretty for Christmas. You know, they had a Christmas tree for every year they had been married. And Hirsch Review was there, so that's how we know it was so pretty. Well, do you know what happened? A storm hit, of course, and we had like 1,000 candles lit at Amner Hall. But did we need more? Yes, so Prince William sent the butler out for more candles, okay? And what do you think happened? You know, Kate went into labor. Well, who had to deliver the baby? Prince William, because he can do anything, right? So the first thing he told her to do was pant or blow, to decrease the urge to push. And of course, Prince William knew that you do not push until you're completely dilated. Then he washed his hands, and he put her to bed, and he elevated the head of the bed. It was a 4-poster canopy bed, okay, with lots of big fluffy pillows everywhere. He knew he needed something clean to put under her buttocks, so what better than his royal robe? So he got that in place, and he's done the vaginal exam, and she's complete, and we're ready to go. Now he knows to decrease touching the vaginal area, and as the head crowns, to tear the amniotic sac if it wasn't torn already. And of course, we all know that Prince William has an amniotic hook on his royal scepter. But hey, it's okay. If you're not Prince William, you can just pinch the bulging amniotic sac. He places one hand on the fetal head and applies gentle pressure. Now, did I say push the head back in until the butler returns? No, I said gentle pressure, because do you want the head to pop out? No, you don't want the head to pop out. Think trauma here. You ease it out, right? Now, when the head is out, feel for the cord around the neck. And y'all remember, this is called a nuchal cord. Then ease the shoulders out, and the rest will deliver fast. Keep the baby's head down. Again, keep the baby's head down. And put a big old star by dry the baby, because we know the baby cannot regulate its temperature. Now, the best place for the baby is on Kate's abdomen. and cover the baby skin to skin, again, skin to skin. Contact with the mom is a great way to keep the baby warm. Then wait for the placenta to separate. Now she can push to deliver the placenta. And when Prince William got the placenta, he inspected it for intactness. Again, intactness. Because if you've got a retained placenta, what's the number one thing you are worried about? I know you're thinking hemorrhage and infection, but remember what we said earlier. Which one takes priority? Pick the killer answer. Hemorrhage is the killer answer. You know that you always want the placenta out within 30 minutes, don't you? That's the rule. I want it out in 30 minutes. If it's over 30 minutes, consider it retained. Everyone knows double clamp and then cut the cord if you are in the hospital. But we are out in the middle of nowhere at Amner Hall. So tie the cord off with something like a clean shoestring or a narrow strip of cloth, no closer than 4 inches to the baby's navel, and a second knot about 8 inches away from the baby's navel. You need to tie off the cord to prevent continued circulation of the baby to the placenta. It will not hurt if the placenta remains attached. If you cannot get medical help, then you will have to cut the cord with a heated knife, a fresh razor blade, or even Prince William's sword. Check the firmness of the uterus, because you know if the uterus isn't firm, Kate's going to hemorrhage. That's right, she's gonna hemorrhage. So, Prince William is over there doing fundal massage. All right, now that you know how the Duke and Duchess of Cambridge's first baby was really delivered, let's talk about the normal postpartum period. First is assessment, and in your student pages are vital signs. Well, the temperature may increase up to 100.4 degrees Fahrenheit or 38 degrees Celsius during the first 4 hours. Now, if the temperature is greater than 100.4 degrees Fahrenheit or 38 degrees Celsius, think infection. The blood pressure should be stable. The heart rate may decrease. A heart rate of 50 to 70 is common for 6 to 10 days. Again, for 6 to 10 days after delivery. Now, I'm going to tell you a secret. If you ever see tachycardia postpartum, what should you think? Hemorrhage. Hemorrhage. Thank goodness you didn't say infection. Think about it. When somebody becomes pregnant, what happens to their blood volume? It increases. It increases by 50%. So my heart rate is naturally going to have to go up to compensate for the excess fluid. But after I have the baby, I've diuresed. So now my heart rate can come down again. The breast will be soft for 2 to 3 days. Again, 2 to 3 days. And then the dreaded engorgement occurs. The abdomen will be soft and loose. Okay, next is GI. Is hunger common? Yes, hunger is common. Because the whole time you're in labor, will they let you eat? No, you might get an ice chip if you're lucky. Now, the uterus just develops a mind of its own immediately after birth. The fundus is in the midline about 2 to 3 finger breadths, again, 2 to 3 finger breadths below the umbilicus. A few hours after birth, it rises to the level of the umbilicus or at 1 finger breadth above. We want the fundus to be firm. We want a firm fundus. What is the first thing you do if the fundus is boggy? Massage. That's right, massage until it is firm, and then check for bladder distension. Again, check for bladder distension. Fundal height will descend 1 finger breadth a day. The fundus will descend and the uterus returns to its pre-pregnancy size. And guys, what is the proper term for this? I'll give you a hint. It starts with an I. Involution. Involution. Now, if your uterus does not involute properly, what are you worried about? Hemorrhage again. And after pains are common for the first 2 to 3 days and will continue to be common if the mother chooses to do what? Breastfeed, if she chooses to breastfeed. Because every time she nurses the baby, what is she going to get a surge of? Oxytocin. And you know oxytocin makes your uterus contract. Now we're going to check out the lochia. Rubra for 3 to 4 days, and it's dark red. Again, it is dark red. Serosa for 4 to 10 days. Serosa is a pinkish brown. Okay, again, it's a pinkish brown. And alba for 10 to 28 days, which is whitish yellow. Again, whitish yellow. Of course, if I'm a new nurse, I'd rather it be more white than yellow, wouldn't I? Yeah. Your client can have alba for up to 6 weeks. And clots are okay just as long as they are no larger than a quarter, a dime, a 50-cent piece, a silver dollar. Which one is it? Nickel. It's a nickel. I'm going to worry about nickels. Hey, let me tell you something. You take that sentence right there over to any women's health center and say, I'm going to worry about nickels. What are they going to say to you? You're a freak, right? Because you know that ladies pass big clots, don't they? And it doesn't necessarily mean they're hemorrhaging, but see, I'm going to worry about nickels early and go get somebody who knows more than me. All right, let's look at urine output. Diuresis. Clients will start diuresing the excess fluid from pregnancy around 24 hours after delivery. So, is dehydration possible? Yes, it is. Why do you think we might be inspecting the legs so closely? For a DVT. I am worried about a DVT here. Okay, next is treatment. Look at perineal care. They need intermittent ice packs for the first 24 hours. Again, the first 24 hours to help decrease edema. Warm water rinses. Sitz baths 2 to 4 times a day, and anesthetic sprays for vaginal deliveries. These help to ease the pain, promote healing, and provide hygiene to the perineal area. These are usually prescribed for all vaginal deliveries and are especially indicated if the client has had an episiotomy, a laceration, or hemorrhoids. Next is change the pads frequently. Now here's the peri-pad rule you've all come for. Are you ready? We do not want them to saturate more than 1 peri-pad. Again, 1 peri-pad per hour. Anything more than that, we're going to have to assume what? Hemorrhage. Now, every time I think about a peri-pad, I always think of this. Have you been told that the computer at the testing center is actually looking for your weakness? That's a common myth that goes around, that it's looking for your weakness. The computer doesn't have a soul, now does it? It's not psychic. It can't look at you and know your strengths and weaknesses, okay? If that were true, think about all the guys at OB Clinical. The computer at the testing center would look at them and say, look at him. He doesn't know anything about peri-pads. He hasn't ever checked a peri-pad in his entire life. Give him all the peri-pad questions. No, the NCLEX lady is actually trying to find something you can answer, okay? So don't go in there thinking that. Hey, you always are going to feel like you've gotten more of what you're weak in. Always. If you have not even thought about crutch walking and you get one crutch walking question, what are you going to do? Call your friend and say, I got 15 questions on crutch walking. Can you believe that? I got ripped. Okay, now back to your notes. Teach to report any foul smell and any lochia changes. Again, any lochia changes. Now, you know when ladies have babies these days, they're sent home pretty quickly, aren't they? So do you have to teach about the lochia thing? Yes. All right, let's pretend you're working at the OBGYN clinic and a lady calls you and says, you know, I made it up to alba and now it's going back to rubra. Do you say rest more or call 911? You say call 911. Now you're thinking NCLEX. Okay, moving on. Let's talk about bonding for a second. Your teacher has told you that bonding between the mother and baby and the father and baby helps to develop trust. Again, it helps to develop trust in the infant. You may have also been taught that in the infant, trust is not an emotional need, but a physiologic need. Again, it's a physiologic need. So that makes it a priority, doesn't it? Maslow says physiologic needs first. So how does a newborn benefit physiologically from bonding? I'm talking skin-to-skin contact here. Well, research shows that skin-to-skin holding stabilizes the heart rate, improves O2 sats, regulates the infant's temperature, again, the infant's temperature, and conserves the infant's calories. Hey, did you know they even found that the breast can change temperature to warm or even cool the infant? Now, you may have heard in the hospital that this bonding, skin to skin, is called kangaroo care. The mom or dad places the baby skin to skin, again, skin to skin, on their chest. The infant is wrapped inside the parent's shirt or covered with a blanket, and the baby is quietly held for an hour at least 4 times a week. The focus of kangaroo care has been the premature baby, but most hospitals now have this as standard care for all babies. Kangaroo care. Remember that. Okay, next is breast care for breastfeeding mothers. Cleanse with warm water after each feeding. Let breast air dry. Now, I don't have anything on there about soap. Soap is too drying. Next is a supportive bra. Again, a supportive bra. Ointment for soreness can be used, or mom can express some colostrum and let it dry. Again, let it dry. Breast pads need to be used to absorb moisture. Again, absorb moisture after the milk comes in. Now, we never want moisture against the skin because what's the skin going to start to do? Break down. So, make sure you change breast pads frequently. They need to initiate breastfeeding as soon as possible after birth. Again, as soon as possible after birth, and alternate breast. This is a bonding thing, but also breastfeeding helps your uterus to do what? To contract. Now, if breastfeeding has to be interrupted, or in other words, the breastfeeding mother is going to have to be away from the baby for a while, what will she want to do? Pump. She'll want to pump, so use a breast pump. Next is increase calories by 500 calories per day. All right, what about fluid and milk intake? Well, here's the rule of thumb. 8 to 10 8-ounce glasses of fluid a day. If you're a breastfeeding mother, you better drink water and fluids because if you don't, you can get a plugged duct, right? And you know you're about to get mastitis. Hey, plugged ducts can also be caused by the baby not nursing well. So fluids are very important in breastfeeding mothers. And don't forget about constipation. They need fluids to help prevent constipation. All right, let's look at the non-breastfeeding mothers. Well, the only thing we can do is hope for decreased engorgement, right? That's what we're trying to do, is decrease engorgement to get them to use ice packs. Breast binders. Again, breast binders. And if your hospital doesn't use breast binders, then get you a big old ace wrap and wrap it around the chest to decrease engorgement. Chilled cabbage leaves. Yes, cabbage leaves dilate capillaries and increase blood flow, and that will decrease inflammation and decrease engorgement. They decrease inflammation and decrease engorgement. And there should be no stimulation of the breast. Now, complications is next, and we're going to start with postpartum infection. This is an infection within 10 days. Again, within 10 days after birth, and the major bacteria you will see are E. coli and beta hemolytic strep. You know where E. coli lives, don't you? And some people are just carriers of strep, aren't they? Yes. So what should you do? Teach proper hygiene like front to back cleansing. You can never teach that enough, and I don't care how educated someone is or how refined or how old they are. You teach it. And good hand washing. They'll usually get cultures and antibiotics too. Next is postpartum hemorrhage. By definition, postpartum hemorrhage is early when there is more than 500 milliliters. Again, more than 500 milliliters of blood lost in the first 24 hours, accompanied by a 10% drop from their admission hematocrit. Now, this is called a dual definition. You must have both to be true. Again, you must have both to be true. Late hemorrhage occurs after 24 hours and for up to 6 weeks postpartum. Causes of late hemorrhage include uterine atony. That's when your uterus doesn't have any tone. And if you don't have any tone, you're going to bleed. Now, how many times have we said hemorrhage in this lecture? A whole bunch. So if you ever get an OB question and you don't know the answer, what should you pick? Hemorrhage. Right, pick hemorrhage. Now, lacerations are another cause, and also retained fragments and forceps delivery. Forceps deliveries can be very traumatic. Don't forget, a full bladder can cause uterine atony, so make sure that your client is voiding. Next is mastitis, and the major bacteria is Staphylococcus. It usually occurs around 2 to 4 weeks. Again, 2 to 4 weeks. Now, let's talk about how people get it. Well, it may be because of poor hygiene, or it may be because you've got somebody who is not breastfeeding properly. Now, signs and symptoms of mastitis include rapid onset of fever and chills. The breast will be swollen and hard, and tender to touch. And they will have malaise. Now let's look at treatment for mastitis. First of all, bed rest. And of course, they're going to want a support bra. Okay, again, a support bra. Because are they going to be engorged? Yes. Binding and chilled cabbage leaves. Binding the breast and use of cabbage leaves will relieve engorgement, but they are only used if breastfeeding is being discontinued permanently. Now you have to be careful with binding because that can cause more stagnation of the milk. If mom is going to continue to breastfeed, she needs to initiate breastfeeding frequently or pump. Again, breastfeeding frequently or pump. And penicillin is the drug of choice. If mom is allergic to penicillin, then they may give her erythromycin. Now, let me ask you something. What if you are a breastfeeding mother and you're on an antibiotic? When do you take the antibiotic in relation to the feeding? Well, you feed the baby, and you take the antibiotic right after you feed the baby. Can you take pain medicine? Maybe. It depends on when you take it and what it is if you are still breastfeeding the baby. Okay, next is heat, like a hot shower. This will cause the breast to leak, which will help relieve pressure and soften the breast. Lastly, feed the baby frequently. Again, feed the baby frequently. Now, what are they going to say? It hurts. I can't. It hurts. Right? So again, that is why we say get in the hot shower. If you are nursing the baby and you have mastitis, you always offer the affected breast first. Again, the affected breast first. Now, newborn care. And first is immediate care. We're going to maintain the body temperature. They're going to do an APGAR, and that's done at 1 and 5 minutes. Again, 1 and 5 minutes. It assesses heart rate, respiration, muscle tone, reflex irritability, and color. And we want at least 8 to 10, at least a score of 8 to 10. Now, most babies get a what? A 9. Why? Purple hands and feet, and we call this acrocyanosis. Erythromycin eye ointment can be used because it will kill Neisseria gonococcus and chlamydia. Okay, what is aquamaphytin? Vitamin K. It's vitamin K, and it promotes the formation of clotting factors. It's an IM injection, and since it's an IM, we are going to give it to the baby in what muscle? The vastus lateralis. Okay, again, the vastus lateralis. That's right. Okay, let's look at cord care now. Well, it's going to dry and fall off in 10 to 14 days. Again, in 10 to 14 days. So clean it with each diaper change using alcohol or normal saline. Again, normal saline. It's a primary healthcare provider's decision, so don't get caught up in this decision. Fold the diaper below the cord. Again, we're going to fold it below the cord, and no immersion until the cord falls off. We need to watch for infection. Again, watch closely for infection. Now, if you've got somebody who is immersing the baby's cord under water before it falls off, it's going to stay wet and moist, and it's going to harbor infection. It's never going to fall off, and then they're going to be like 18 years old on the beach and can't get a girlfriend because they still have their cord. Okay, let's talk about some newborn complications, and hypoglycemia is first. Now, why do some babies experience hypoglycemia after birth? Because they're not getting glucose from whom? The mother. They're not getting glucose from the mother. Babies at greater risk for hypoglycemia include those that are large for gestational age, small for gestational age, and babies of diabetic moms. Next is pathologic jaundice. Now, when does this occur? The first 24 hours. That's right, the first 24 hours. And it usually means an RH or ABO incompatibility. And we're going to talk about RH incompatibility in just a minute. Okay, what about physiological jaundice? When does this occur? Again, after 24 hours. After 24 hours. It is due to the normal hemolysis of the excess RBCs releasing bilirubin and liver immaturity. All right, next is RH sensitization or RH factor. The first thing you've got to do is put a big star by the first sentence, because if you don't get that, you'll never get it. It occurs when you have an RH negative mother with an RH positive baby. Negative mom, positive baby. Negative mom, and positive baby. So let's look at the first pregnancy. RH positive blood from the baby comes in contact with mother's RH negative blood. Again, mother's RH negative blood. This is most likely to occur when the placenta separates at birth, during a miscarriage, an amniocentesis, or when there is trauma to mom's abdomen. The mother's body looks at the baby's positive blood as a foreign body, because isn't it different from her negative blood? Yeah, it is. So the negative mother produces antibodies against the RH positive blood. Anytime a foreign substance gets in your body, what do you make? You make antibodies. So that's what the mom is going to do, because the mixing of blood occurs at birth. The first offspring is not affected by the antibodies, because if I have my baby today, do I have antibodies today? No, it takes time to develop antibodies. So that's why the first offspring is not affected. Now, the chances of an RH negative mom forming antibodies to a RH positive baby increase with each pregnancy. Well, why? Because with every pregnancy of an RH positive baby, there is a risk of the mom's RH negative blood coming in contact with the baby's RH positive blood. So what happens if an RH negative sensitized mom gets pregnant again? Well, since she has already developed antibodies for RH positive blood, what will happen with this second pregnancy? The antibodies that the mother has developed will enter the baby's bloodstream through the placenta. In response to the mom's antibodies, the baby's red blood cells will begin to break down. The breakdown of red blood cells is known as hemolysis. So, since the baby has an increase in the breakdown of red blood cells, it tries to compensate by releasing lots of immature red blood cells. And the fancy name for the increase of immature red blood cells in the fetal circulation is called erythroblastosis fetalis. Erythroblastosis fetalis is a hemolytic disease that can be fatal to the growing fetus in utero. So let's talk about diagnosis and treatment. The indirect Coombs blood test can be done on the mother. It can be done on the mother, and it measures the number of antibodies in the blood. The direct Coombs is done on the baby, and it tells you if there are any antibodies stuck to the red blood cells. The direct Coombs is done on the cord blood. Treatment can involve a lot of high-tech procedures, but one thing they will definitely do is frequent ultrasounds. Again, frequent ultrasounds. They are closely watching the growth of the fetus, and when the baby stops growing in utero, it's time to consider delivery. Now, when is RhoGAM given? It is given to the mother within 72 hours after birth. Okay, again, within 72 hours after birth. And most primary health care providers give RhoGAM twice. Again, twice. Once at 28 weeks gestation and again within 72 hours after birth. The 28-week dose is given just in case there has been any mixing of maternal and fetal blood. It is given to protect the present fetus just in case there are any antibodies being produced. Now, who is the 72-hour shot going to protect? The next baby, right? Yes, the next baby. That is why you see two different shots given, one for the fetus in utero and one for the next baby. Now, RhoGAM is also given with any bleeding episode. Again, any bleeding episode during pregnancy. Okay, let's look at how RhoGAM works. It destroys positive fetal blood cells that get into the mother's negative blood, and it must do this before antibodies are formed. If antibodies are formed, then RhoGAM does you no good. That is why it must be administered within 72 hours of delivery, before antibodies have time to form. Once the mom is sensitized to Rh-positive blood, it's too late to give RhoGAM. Okay, to finish up maternity, let's do a critical thinking exercise. Look at this scenario with me. An obstetrician already has 3 clients on the labor and delivery unit receiving oxytocin for induction of labor. All 3 women are 38 weeks gestation. The labor unit has 6 beds and 4 nurses are on duty, 3 RN staff members and 1 RN nurse manager. The primary health care provider calls from the office to inform the nurse manager that a 4th client is en route to the labor unit with orders to start an oxytocin induction. Which next action by the nurse manager is priority? Assign yourself to monitor 1 client receiving Pitocin? Request a delay of induction until 1 client delivers? Call nursing supervision requesting a float nurse from another floor? Or report the primary health care provider to the PRO review committee for indiscriminate inductions? Okay, take a minute and decide on your answer. Did you select number 2, request a delay of induction until 1 client delivers? Yes, this is the correct answer because the priority is always client safety. Now, look at option number 1. It is unsafe. The nurse manager must be free to circulate and assist if any problems occur on the unit, or if the clients are delivering simultaneously with 1 primary healthcare provider delivering all 3. Or if a complication of oxytocin induction occurs. If you picked option number 1, you're telling the NCLEX lady you're a killer. Okay, option number 3 is unsafe because a non-OB nurse is not going to be knowledgeable of all the subtle client changes to monitor for in a client receiving oxytocin. They would be unprepared for things like a precipitate delivery or a ruptured uterus. Again, you're a killer. And lastly, option number 4 is viable. The primary healthcare provider should have to answer to their peers, but our priority is always client safety first. When answering priority questions, client safety will always be top priority. All right, guys, that's it for maternity. Thanks for watching.